Major East Coast cities in the United States shut down bars and restaurants ahead of St. Patrick's Day celebrations. They were worried that one of the biggest drinking holidays of the year would exacerbate the spread of the novel coronavirus as COVID-19 slammed into the Western Hemisphere like a storm surge. Businesses boarded up, schools emptied, and millions of Americans nationwide hunkered down. In healthcare, private practices and hospitals alike canceled elective procedures and postponed visits as much as possible. They too moved online. One of the cities that effectively canceled St. Patrick's Day was New York City, and for good reason. Within only a few weeks of the national quarantine, New York City had more confirmed cases of COVID-19 than any nation on Earth. As of the unofficial start of summer, Memorial Day, the curve appears to have flattened in the U.S. Sports leagues are making plans to resume play with no fans in attendance. Stores in some states are open at fractional capacity, and citizens are starting to visit family and friends.
So I have 1,400 patients on my panel. Now that we're a little down from the acute phase, we're turning to all of our outpatients who are MIA, and I'm trying to call the ones who have scheduled visits, but I also am trying to call the ones I'm worried about. That's
Dr. Danielle Ofri. Dr. Ofri is a physician at Bellevue Hospital in New York City. Dr. Ofri points out what many have been saying. Where are all the MI and stroke patients? Where are the traumas? In making her calls, she found out where they are, doing their very best to avoid the ED.
She was doubled over in pain, having had a hysterectomy 2 or 3 weeks ago, and she wouldn't go to the hospital. I had to force her to go, and she was in the OR that night with an abdominal intra-op infection and a pulmonary embolus.
For healthcare workers, two major questions are looming. First, how are all of my patients doing? And second, what are we going to do now? This is Medicine in the Machine, a conversational podcast from Medscape about how medicine is intersecting with technology now and how it will in the future. Hosted by Dr. Eric Topol and Dr. Abraham Verghese. I'm a producer on the show, Nick Andrews. In this episode, we welcome back to the program Dr. Danielle Ofri to talk about how hospitals will emerge from the COVID-19 surge. Please welcome now the hosts of the show, Dr. Eric Topol and Dr. Abraham Verghese.
This is Eric Topol, and I'm pleased to introduce my partner.
Hi, this is Abraham Verghese. I'm very pleased to welcome our guest today, coming back for a second visit, and that is Dr. Danielle Ofri, who has been right in the thick of things in New York City at Bellevue Hospital at NYU. And we're really delighted to have her back on board, this time talking in an entirely different time frame. It seems like we're talking in another world from the one that we were in when we first talked to you. So before we get going, Danielle, how are you and how are you doing and how have you weathered the storm?
Thanks, Abraham. Eric, it's great to be back. Yeah, it does feel like another world. We talked, I think, before we even started with COVID. So, I think someone sent out a meme that this is a leap year, that February had 28 days and March had 300 days and April had 10 years. And that is what it has felt like in the clinical world. I mean, things really picked up toward the end of March, and I've never seen our hospital move like this before. I mean, for context, to get a water cooler at Bellevue, I think it took like 2 years. But in the space of 2 weeks, we almost tripled our ICU capacity, added, I think, another 50 negative pressure rooms, doubled our inpatient capacity, increased our medical teams from 8 to 22, went from 1 MICU team to 10 MICU teams. It was something like I've never seen before. And one of the reasons I realized that we were able to survive, I've learned in retrospect, is back when Ebola came, Bellevue opened its special pathogens unit, and we did treat the one patient in New York with Ebola, Dr. Craig Spencer. But that special pathogens unit never closed. And in fact, the special pathogens team was meeting weekly since Ebola, often with not much to do, but keeping tabs on MERS and SARS and Lassa fever, yellow fever, all the things that are happening around the world that can definitely turn up at a place like Bellevue. So when the novel coronavirus turned up in China in December, it was already on our radar. And I think that gave us maybe a week and a half or 2 weeks head start on many other hospitals, and that was critical. And so we were able to keep ahead of the tide. Now, thankfully, we're at a plateau and not back from the abyss, because this plateau now is really sticking. We have about still 50 patients in the ICU with COVID who are not extubatable, and probably 180 on the wards. Nevertheless, we're now approaching the idea of what happens next, because we have the rest of our patients to take care of, and what do we do now?
Wow, that's just pretty incredible. You know, I think most of our hospitals also went through this huge gearing up and getting ready, but the difference is we never saw the numbers that we were worried about, never got to really use our surge ICUs. And to think that you have, did you say 50 patients still on ventilators in your hospital? That is really staggering when we have, I think, one at this point.
It's really, and I mean, the issue now is long-term acute care facilities for these patients. I mean, the number of codes and rapid responses have gone down, so you can really feel there's not the churn of patients coming in, patients going out, patients sadly dying. That has really lessened. But now we have a core of patients who are really experiencing the long-term issues. And the other side of it is the renal aspect. I mean, really no one was prepared for up to a third of patients in the ICU needed some kind of dialysis. And you simply just can't ramp up dialysis that quickly, staff and machines and nurses and space. We ended up doing a ton of peritoneal dialysis. If you can believe, in the ICU, PD really saved the day. And we had dermatologists doing peritoneal dialysis. Really, everyone got trained in it. It was quite something to see.
Yeah, there's a lot to unpack there, Danielle. I mean, I think, for one, the multi-system attack from when it was first thought of as a pure lung play, and then now recognized that there's no organ spared, essentially, and the kidney especially, because it has a high ACE2 for targeting of the virus. But the other thing is that you're getting at already is that these prolonged intubation, often between 2 and 3 weeks, and of course some handling much longer, it seems really extraordinary and challenging, because all the other things that can happen while a person is intubated so long.
Right, and all these patients, of course, have to be largely sedated, paralyzed. I mean, now many are being trached, so that's changing the dynamic a little bit, but it doesn't take away the long-term damage of intubation. Plus, you know, the vascular complications have been large, and that's probably why the kidneys are being affected so much. But and even seeing encephalitis, COVID encephalitis, and now the pediatric issues have suddenly arisen. You know, we went into this thinking that kids were really relatively spared, but now we're seeing this multi-system inflammatory disease that seems to be a combination of an inflammatory and vascular issue that is quite terrifying. And it's changed the landscape of what we'll do about schools and camps and pediatric clinics. It's really scared everyone.
Yeah, and I think there's over 100 reported children's cases in New York alone. Yes. No less a few have already died. I mean, it's extraordinary. And another miscue, there's been so many of those. The idea early on in February and March that, oh, this was only, you know, for children would be spared. That's not the case, although certainly unusual.
And right now, we're really scared about a second wave, because as all the states begin to loosen their restrictions, because we haven't really changed the treatment options at all. We've only changed the spread. And so now that we open up, we're fully expecting another wave to be coming around. And it may not be in New York City because we're still staying put, but I think in the rest of the country, they may be seeing the surge that they hadn't gotten before.
Danielle, I happened to visit New York City in the third week of February, and it was a time when we had several cases here in our county, and I was meeting with my publishers and going out for lunch and dinner, and I mean, I think I was just struck by how relatively unaware they were of it. I mean, they were very aware of it, but it seemed far away. And my hotel was right in the center of Times Square. And I kept thinking, this is unreal. There is no way this is not going to come here. And now I find myself thinking about all the waiters and all the various hotel people that I saw whose livelihoods are completely altered by this. Give us a sense of the economy around you, where you are at Bellevue and that wonderful earthy neighborhood where Bellevue sits?
Well, what's interesting is that, we call it Bedpan Alley, that stretch of First Avenue, because we have NYU, we have Bellevue, we have the VA. A little down the road is Beth Israel and Beekman, and a few blocks up is Cornell and Sloan Kettering. So First Avenue is still hopping. There are people, we're coming and going. In fact, we have more than usual because of all the staff surging. But go out a block or two, and it's like permanent Sunday morning in New York City. That early Sunday morning where everything's quiet and the birds are chirping. It's remarkable in both this beautiful and terrifying way, because you recognize that the effect on people economically is powerful. There was just a piece in the BMJ today with stats on the mortality in the UK population, and it was low-income males that had disproportionately high mortality rates, with security guards being the highest, then taxi drivers, bus drivers, chefs. And these are the people we are certainly seeing, and they're taking the economic and the medical hit all at the same time. And I think it's going to be a permanent change in our society.
And one of the other things to note in the outside of the hospital setting is the fear of patients coming to the hospital and the potential of all the collateral damage. I mean, today there was a report of a big drop in heart attacks within the Kaiser Permanente system during the March and April. And I wonder what your experience is, certainly in San Diego, our hospital outside of COVID, we're seeing so many fewer patients. And I presume that is representing fear of people coming in. But what are your thoughts about that, and what have you seen?
I'm seeing this absolutely. Now that we're a little down from the acute phase, we're turning to all of our outpatients who are MIA. So I have 1,400 patients on my panel, and I'm trying to call the ones who have scheduled visits, but I also am trying to call the ones I'm worried about. I've uncovered several patients who have died, some of COVID, some of other things. I called a patient, sent a message needing a med refill, which I almost just passed off to, a PA to do, but I thought, I'll call her. And she was doubled over in pain, having had a hysterectomy 2 or 3 weeks ago, and she wouldn't go to the hospital. I had to force her to go, really get her family to get her, and she was in the OR that night with an abdominal intra-op infection and a pulmonary embolus. Yesterday, I got a call from the adult child of a patient, and that the patient with dementia was being abused in her home by another relative. And I spent an hour getting protective services involved, and all of these things are happening. And the more I call my patients, the more I am learning. And it's terrifying because there's so many of them, and they're all hiding out, terrified to come. I spoke to another patient today with severe anxiety and asthma, and they're setting each other off. And every time she wears a mask, that sets off anxiety and asthma and hard to breathe. And so her psychiatrist has upped her psych meds, but now she's sleepier. And so she's sleeping all day and doesn't even know what day it is. And all of these things feed on each other. And the last thing I've been discovering is food insecurity. I'm asking every single patient, do you have enough food? And for many of them, the answer is no, or very little, or they're living on rice and potatoes. So you can imagine their A1C and glucose levels are off the wall. And some are rationing insulin because they're too afraid to go to the pharmacy. Getting INRs for the patients on Coumadin has been this unbelievable task. I've tried to push as many patients to DOACs as possible, but some people need to be on Coumadin. They don't want to come in. And of course, many of the patients on Coumadin are extremely high risk, and they're the last patients we want coming into the hospital. So trying to get home labs, which is a whole insurance Byzantine nightmare to navigate. So the collateral structural issues that we have to face are just killing us, and they take so much time. And when I think about, the hospitals are hemorrhaging money, none of this work is reimbursable. We're putting in hours of work, and I wish there were a way to capture the work that we're doing. Physicians, the nurses, the social workers, no one's sitting on their hands, but it's not capturable. And so it's all going, there's a note in the chart, but no one's getting reimbursed for this.
Stay with us. We'll be right back with Medicine and the Machine.
Welcome to Medscape's latest podcast series, Medicine and the Machine, featuring Medscape's Editor-in-Chief, Dr. Eric Topol, and Master Storyteller and Clinician, Dr. Abraham Verghese. Remember, you can find the latest in medical news, expert perspectives, clinical tools, continuing medical education, and more at medscape.com.
One of the things that's been striking about this epidemic, at least for me, is watching the way leadership has stepped forward at small and big hospitals alike. And the principles that seem to carry the day are clear communication and transparency and, assigning clear responsibilities, all the things that we're not seeing in the federal government, in a sense. As you look ahead, Danielle, and we have very similar problems with, a big deficit and worries about how to make money. I know you don't have a crystal ball, but as you look ahead, what are some things that strategically small and big hospitals might be doing? Because, we have to move on. We have to keep moving. We have to keep surviving. What is your leadership doing? What do you see a year from now?
Well, the whole experiment in telehealth, which we had been tiptoeing toward, we got, thrown in and we're there. Although, a patient called me today and said, I have a telehealth visit for you, but when do I come in for my physical exam? And I thought of you, Abraham. I said, we just can't do a physical exam now, and it's not going to be for a few months, and we'll try our best with get your blood pressure checked and, finger sticks, but we're not going to have that. And I do worry that we're going to miss a lot. Nevertheless, we don't have a choice. So we have to ramp up the infrastructure for doing televisits, video visits, but the hospital can't survive unless we find a way that insurance can be covering that, the amount of clinical work. And that will require some political muscle. And I think the hospitals do need to band together to make this point because I don't think our political leaders recognize this. There was just an article today that the New York City public hospitals, some may have to close. The economic hit is so powerful. And many of the bigger private hospitals have larger endowments. They have, all that money in the bank from those elective procedures, even though they're on hold now. There's a cushion, but city hospitals don't. So that's one thing. The second thing is to rethink a lot of the elective care we were doing. All that sort of gray zone knee arthroscopies and back surgeries, which don't have a whole lot of benefit, certainly on average, although certainly for some patients individually they might, which is what I think hospitals were living on. We certainly realize that, we can survive medically without them, but I'm not sure if we can survive financially without them. And that just points to our priorities being backwards. We want to be surviving on the real care, the patients with their diabetes and vascular disease and obesity and depression. But that's a big political lift.
Well, you're bringing up that point about the economists showed us that the biggest reduction in GDP and the hit to the economy is the healthcare sector, and it's isolated to the elective procedures and operations. And so there is a dramatic reduction, close to zero for this stretch. And is there going to be a rethink? Because we do know, certainly in the U.S., there's overutilization of surgeries and procedures, as you've alluded to. So that'll be interesting. I also wanted to get to your telemedicine point and the exam. The telemedicine as it exists today is this video chat, but it could be transformed to a better version where with sensors and ability to do imaging through smartphones and all sorts of things, it could get objective data. It wouldn't be the same as a hands-on physical exam, but we should be thinking about those things because the reliance on telemedicine over the next year or two as we confront the ongoing pandemic may become more a better way to approach rather than having no objective data, except for sending people to labs or sending them for scans. The other question I had for you, though, Danielle and Abraham, is this trade-off that, when you do a televisit, a video visit, you actually are looking at the patient. You're not typing on a keyboard. You don't have a mask on. And while it's not ideal, there are obviously substantial trade-offs. I wonder if it's as bad as some people have portrayed it in the past.
I find it's actually not as bad because I can type. I'm not doing video right now. We're still piloting that. So I can type while I'm talking to the patient. Whereas when I'm with them, I very much want to maintain eye contact. So in some ways, it frees me up a little bit, and maybe I feel a tad guilty about that. The other efficiency that it's brought in is that we're not so tied to the schedule because there isn't the crush of the patients waiting in the room. I find that so anxiety provoking. With a phone call, if we call 10 minutes later, 10 minutes early, although that is largely dependent on the fact that everyone is home now, and when people get back to their real lives, that may not be as easy. But I've found time, for example, to go back and do chart digs in the moment, which I could never do in real time. I have to wait till later, and of course, later never comes. But now, because the patient's not being inconvenienced by waiting in the waiting room, I can take the 10 minutes and I found actually a number of clinically relevant things that would have been missed in the normal world. But the trade-off for me is that besides the physical exam being helpful for diagnosis, I find it's also extremely useful for the history. And now that most of our histories take place with a computer between us, it's not really a strong, close conversation. But I find that the physical exam becomes the locus for the very intense conversation. And countless times, it's during the physical that the patient will tell me things they didn't reveal before. Sexual symptoms, depression issues, abuse, things they've forgotten, but a lot of things that are very uncomfortable to talk about only come out when we're in this more sort of intimate and environment of touching and talking. And when you're sitting with a computer, people are going to offer, oh yes, I was beaten up by my spouse, or oh yes, I'm having erection issues. That doesn't come up in the sitting over the desk kind of conversation.
Right.
I think over here at Stanford, we have a lot of experience now with virtual visits because that's pretty much all we were doing until very recently. And I think people are in two camps. There are those who are increasingly frustrated with it, but then there are those who are showing us how to do it well. And as Eric knows, we had championed something called the Presence 5, sort of a mental checklist of things one does with a real patient at that first moment of meeting to optimize a relationship. And we've now adapted that to the virtual visit. And there are certain things you can do, like, for example, making sure that you're looking into the camera, not picking up other things on your desk. And some people have pointed out that you actually get to see the patient in their home environment. You get a sense of their own sense of safety. You get to ask them, how are you doing? How do you feel about, the quarantine? So it's been interesting. I think it'll take a few more months for us to digest the nature of the experience. We ramped up virtual visits 100-fold. It was something that we were just thinking about in the past, but now it's, it was scaled up massively. And I think there will be in the future a very, very much a role for mixed model of physical visits along with the sort of intimate glimpse into people's homes. And also it gives our providers who have children the opportunity to do this in the after hours where patients also want to have visits in the late evenings. So there's going to be a lot of changes to medicine because of this experience.
And so
I think that
I believe, we're looking at the model of maybe, let's say in June, having 10 to 20% in-person visits and 80% televisits. And then we can prioritize those who truly need the physical presence and those for whom we can do a televisit. And the truth is, for patients, the televisit is extremely convenient. Our patients would have to take a half day off from work to get to the place, to wait, all of that. And it made it very difficult. And so now many patients really, I think, like the televisits for that reason.
Yeah, I think the other point to circle back is that because of patients clearly having a much higher threshold to get care, to get seen, that the telemedical route will help to reduce that problem and some of the harm that can occur without medical attention. And I think we geared up substantially, like Abraham was saying, at Scripps, and that the clear embracement of this route is also, I think, emphasized by, as he pointed out, the window into the person's home that you never otherwise would see. So a lot of interesting trade-offs that I don't think any of us fully had anticipated.
Yeah, of some of the downsides, many patients don't have privacy in their home. Right now they're quarantining home with family and kids or parents and relatives. And so to find a quiet spot to talk about personal things can be difficult. But the upside is the patients can grab their bottles of medicines and read off what the label says when we read they're there. If they've forgotten, usually they forget to bring them to the visit. That's been an upside. So, I mean, more of what we're dealing with now is because we did see patients more frequently, the messages between the visits were relatively small, just need a refill of Flonase. Now with this big gap, these messages in between are often quite serious. And so a lot of us have this panicky feel that we can't take a day off because there could be a message that could reveal something horrific and horrible, as so many of these messages turn out to uncover. So we just were told this week that we need to take vacation over the summer, and nobody really wants to, and there's of course no place to go, but it's hard to, I'm technically part-time, but I can't seem to abide by that now because I know patients are sending messages and leaving messages all the time. And all of my colleagues report the same thing. They can't stop obsessively checking for messages because everything seems so fragile and friable right now.
Another question I had is about the esprit de corps. Before the pandemic arrived, there already was a global crisis of physician burnout and clinical depression even, as well as suicides. And now the healthcare workforce has gone through a stress test like no other precedent, with not just having to confront the patients affected who were so desperately sick, but all the unknowns where there wasn't any testing to know whether someone even had an infection or not, and then the lack of gear. And I wonder how that is settled in on your colleagues at Bellevue as to, has this made things even worse that were already bad, or has this united people against a common enemy, the virus?
It's actually a bit of both. The esprit de corps, on the ramp up was incredible. And I think the sense of purpose overshadowed everything. And I'm sure it varies in different places, and partly is we never ran short of PPE, although we were economizing at times. And I think for places that ran out of PPE was a very different experience of losing faith in the ability to protect the staff. So knock on wood, we didn't. And our clinical leaders were really out front, and that helped a lot. And working in a city hospital, you're used to, rolling up your sleeves and doing what it takes, whether it's transporting the stool sample yourself, wheeling the patient down to X-ray. No one's ever been sort of too high and mighty for that. So it wasn't much of a stretch to start doing whatever it takes, open up a MICU in the endoscopy suite and whatever you need. You can be an attending and go help out and do, the nursing duties, or you can be an ophthalmologist and go be a medical intern, as we had many of those, and people's egos were really put aside, which was remarkable to see. It was an amazing esprit de corps. I think there was more existential terror. We were comparing this a bit to HIV, which many of the people who are in the leadership position trained under, which also was a terrifying time of an incredible, immersion in death and destruction. It wasn't quite as contagious in the same way. It wasn't respiratory, but it was certainly frightening. But I think for this generation of house staff, this was their first foray into the world that many of us faced. And we didn't know if we were fully protected. Now that we know that, I think we did our first round of antibody testing, and our rate is actually lower than the general population in New York. So I think our PPE was working. And I think, if you got it probably in March before we were doing it well. But once we knew what we were doing, other than a small, subset where there was difficult circumstances, mostly the PPE worked. The third area, I think people felt like the residents were requesting hazard pay, and I think they should have gotten it. And there was a little pushback from higher up saying they should, it's how unseemly to talk about money, but it was less about money. I think about recognition, that we've asked really above and beyond the call of duty, and the same for the nursing staff, really to recognize that we've really put people in a position. So yes, esprit de corps was great. I think what you're seeing now, though, as we get away from it, once the adrenaline stops going, it's very awkward. And I think now is when the issues are coming up, when people suddenly have time to look at their hands, look at their lives, look at their kids who've been struggling home with schooling, remember their relatives who are isolated, they haven't really been calling. And so many people are finding the issues are arising only now when the tide has come out a little bit.
Yeah, I think one of the most distressing things for our residents has been their sense that they are feeling guilty of watching and hearing stories of their colleagues, their friends, their classmates in New York and elsewhere, really in the thick of things. And I'm so glad to hear that the esprit de corps has sustained you. I think what's most distressing to many of our house staff, I suspect, is the dichotomy between the science that we're aware of and sort of the way the government might cast that science, or the way politics gets in the way of what seems like clear-cut decisions. I think that this may be their first moment of disillusionment, I suspect, with the realities of how policy and facts don't line up. Or maybe I'm mistaken. They already know this a long, long time ago, but I certainly feel it.
I think it's the first time they actually felt it. I think we've seen it, but when you feel it in action, look now as you see the rise in cases in places that are not abiding by the public health recommendations, you can see it happening, and for sure it will happen. But it was painful to see, and people just keep slamming their heads against the wall when something seems so obvious. And one of the frustrations is a lot of people on the clinical side feel that, the American public, they haven't seen the bodies. And if you think back to the Vietnam War, and what really turned the tide was when the public had a visceral and visual view of what war meant. It was very different. And I think it really swung public opinion. And right now, the public sees healthcare heroes, a word that is so uncomfortable for most people, but they're not really seeing the true devastation. And I think that would change. If the nightly news was showing us the bodies, the deaths, the funerals every night, we'd have, right now people see these beautiful graphs on the evening governor's roundup, but they're not really seeing the people. And I think that would change the politics of what's going on now.
That's profound, Danielle. I think you're so right. I think that's beautifully said. I have to remind our listeners that you are a writer as well as an extraordinary physician. And I imagine that the writer part of you is processing all this. What are some things that you see yourself writing on or commenting on or tucking away for future reference?
Well, I've been trying to sort of assemble my thoughts actually now as we're getting a little bit out of the abyss. And on the one hand, the day-to-day life has been chronicled very well. Sherry Fink has written, and many other reporters have really brought people into what the ICU life is like. I feel like I want to think about the larger picture. You mentioned before the issue of guilt, and that's still present here in New York, trust me, because, if you're on the wards, you feel guilty you weren't in the ICU, and if you're doing the outpatient calls, you feel guilty you weren't in the wards, and if you're doing leadership, someone's got to do the scheduling. The scheduling was critical, but then you feel guilty you weren't doing any clinical work. So there's plenty of guilt, guilt around. If you have the weekend off, you feel guilty because your colleagues are in-house. So we're all grappling with that. And so I'm trying to step back a little bit and see more the totality of how we're all being affected. Still in progress. For me, the weirdest thing is that my book was published on April 21st in the midst of this. And
I was going to ask you about that, right?
But the funny thing is that my previous book, the one on what patients say, what doctors hear, came out a week after the inauguration of Donald Trump. And as you can imagine, as you remember, the media then just got completely sucked in, and all the books that came out in those weeks and months just completely sank. So this time we thought, okay, let's pull the publication date as far back from the 2020 elections as possible. How about the spring? What could possibly happen in March and April? And so we picked a publication date of April 21st. And so there we were. And so it's like a baby coming out. There's, you can't stop it now. So it's been a little bit of a weird thing. How can you even think about it? But, here it is.
Well, your book, When We Do Harm, is amazing. I don't know there's a better book that's really written about medical errors, and also from the stories and the personal vignettes that you transmit there. It's an outstanding book, and I hope you'll get, in spite of the pandemic background, the recognition it deserves.
Well, thank you. I mean, one thing.
This has been terrific. Oh, go ahead, Danielle.
I said, one thing I have been thinking about as a confluence of these are the errors that have been made in the wake of COVID, and how our approach to a pandemic and urgent situation does put us prone to certain kinds of errors, and which are justified, which could we have done better. So, more on that soon, but I'm trying to kind of pull these two things together if at all possible.
Terrific. Well, we've covered a lot of ground, and we probably should get back again with you. You're the first guest we've had twice already, Danielle. So that tells us that we're going to be having you more often too. I really appreciate your perspective, wisdom, and this look not only to the present, but to where medicine in America is headed for the future. So why don't we stop here, and thank you for joining us again, Abraham. As always, terrific to be with you. Medicine and Machine, and I will look forward to our next podcast that will continue to try to delve into the most important aspects of medicine and how it'll move forward.
Thanks, guys. Thanks, Eric. Thanks, Abraham.
Thank you.